Today, I want to talk to you about a very specific topic. It's not flashy, it's not exciting, but I think it's something that it's nice to review, it's nice to talk about because it's one of the things that I do in my clinical practice all day long. And that's looking at panorexes, specifically looking at panorexes in regards to lower third molars and whether or not I want to defer removal of a lower third, talk to a patient about a cornectomy, or take a tooth out. Those are basically the three basic options that I think of and give my patients. So, what I want to dive into a little bit is panorexes, what I'm looking for, and how I use that to help with my decision making. And people go, well, wait a minute. Why are you talking about a Panorex? Why are you discussing Panorexes? We got CBCTs out there. And that's true. I have a CBCT. Typically, that CBCT, when I take an image or have one of my team members take an image of a patient, it will pull up in a Panorex format first off. I will use that as a screening tool. I'm looking for pathology. I'm looking at the nerves. I'm looking at the sinuses. When it comes to the lower thirds and looking at the canal, I'm using that as a screening tool to see if I even need to delve into the individual slices in a three-dimensional view. So I will use the Panorex on my CT scanner as a screening tool pretty much every time. Now, I also get referrals from other offices. So I'm getting two-dimensional images sent to me, email, paper, in the mail, whatever, and I'm using those to screen to see if I need to take a new CT on a patient to evaluate whether or not a lower third is involving a nerve or in close proximity and high risk. So with that being said, what am I looking for when it comes to panorexes? So the first thing, I'm going to just throw a Panorex up here. So the first thing that I look for is whether or not the superior border of the canal is intact. I'm generally looking to see where the canal is at in relationship to the body of the mandible and the apical aspects of the lower molars, but I'm also looking specifically for the cortical borders of the canal. Is it clear? Is it well defined? Is it intact all the way through? Or when it approaches the roots of the third molar, does it become disrupted? Does it become diffused? Does it become unclear? Or is it broken? That is a huge one. That is a huge one, folks. So that's one that you want to be looking for. Another thing that I look for that's well represented in this image is whether or not the root of the third molar is deflected. And in this case, it's obvious that it is deflected. This is another clinical sign or radiographic sign that you are in close proximity to the nerve and you have a higher risk of nerve injury if you take this tooth out. As a side note, this one's a case that came to me recently. I ended up doing a cornectomy on this because the pericoronal pathology, if that had not been present and the patient was asymptomatic, I would have left this alone. I wouldn't have touched it. He was an older gentleman in probably his 50s, but I ended up doing cornectomy on this. So we're talking about the superior cortical border is 1. Deflection of a root would be 2. Number 3, that's represented here, is how the canal, you can see as the canal approaches the apical portion of the third molar, it starts to change direction. It's not straight. It diverts. That is a big one as well. That's the third thing that I'm looking for that is problematic and something that I would consider in taking a three-dimensional image and talking a little bit more in depth about whether or not we want to take the tooth out or leave it or do a cornectomy. This is also, as you look at this canal, there's a little bit of narrowing at the very tip of the apical portion of that root tip. You see the canal is wider as you go more proximal, and then as you come forward, it narrows as it reaches the root tip of number 17. That is, again, another radiographic sign that you want to be aware of. And you do your CT scan or you talk, different options. So we've talked about superior border of the canal. We've talked about deflection of the root. We've talked about narrowing of the canal and diversion of the canal. All of those are all problematic when it comes to wanting to take out a third molar and avoid risk to the nerve. This one that I'm going to pop up here, this one is a little different, and this one's a little harder for me at times to see. That's when you get darkening of the apical portions of the roots. You can see on the distal root of this number 17 a fair bit of darkening, a little deflection, canals diverted, but the darkening is what I wanted to point out here. And I'm not talking about incomplete apexification. I think that's the proper term. Having to go back in my memory banks there. I'm not talking about open-ended apex here. I'm talking about a patient that's, pretty much has well-developed third molars, but as you approach the apical portion, the root becomes darkened. That's indicative of involving the nerve, and we want to be aware of that, especially when we're talking about removing these teeth. This image that I'm bringing up represents something a little different. Now you can see, going back through our list, disrupted superior cortical border, deflected roots, and here you can see how the root tips narrow. Now they're deflected, but they also narrow at the superior border of the canal. So narrowing of the roots is another thing. One of the final things, I don't have a good image of this, is looking for root bifurcation on an x-ray, looking to see if there's a hole through the root where the nerve may actually penetrate the roots of the third molar. Sometimes you'll see that notching with that bifurcation. I don't see a lot of that. I've seen some in my career. That's definitely a no-go. You get in there and you start tugging on that tooth to take it out, and you're pulling on the nerve, and you could tear the nerve. You could definitely stretch the nerve and have the patient at least have a transient or temporary nerve injury. So you want to be aware of that. And that's something that, I don't see much of, but you have to be cognizant that it can happen, and you can see that from time to time. So those are just some ideas that I have about inferior alveolar canals and screening panorexes as to whether I move to a CBCT and look at individual slices and have the conversation with the patient about coronectomy versus deferral or removal. So just for a quick review, let me go back over those for my own sake as much as anybody else's. Number one, superior border of the inferior alveolar canal is disrupted. That's a problem. Number two, you have deflection of the roots on the third molar. You have diversion of the canal. You can have darkening of the root tips. You can have narrowing of the root tips. You can have narrowing of the canal itself. And then you can have notching or bifurcation of the root tips or perforation of the root itself by the canal. Those are the 7 things that I'm kind of looking for. You see some more frequent than others. But the top ones in my mind would be disruption of the cortical border, darkening of the roots, and diversion of the canal. Those are the 3. Those are the 3 big ones. If I see those, then we're talking deferral or coronectomy at best. So I hope all that makes sense. Hope that helps when you're screening panorexes and deciding what you want to do in regards to lower third molars if you're doing those in your office. Or even for knowledge, if you're referring those out, you can even mention it to the patient before you refer them, as the fact that whoever you refer to, they're probably going to talk to you about potential nerve injuries or nerve involvement. And that way it tees up the situation for your surgeon of choice as to who would be managing that. Finally, if you're doing oral surgery in your office and you're interested in oral surgery topics and conversations around oral surgery, I'm going to be posting more videos, and if you want to, go ahead and hit the subscribe button, and that'll bring you into the loop and open up communications. Additionally, if you have comments about this video or any of the videos on the website here, you can certainly chime in and let us know. I am in particular interested in, the topic that we discussed. If you have different opinions, and there's a lot of different ways to do oral surgery, and I'm not one to tell you a specific way, but I'm always interested in learning. If you have different ideas, different concepts, different approaches, different techniques, I'm happy to, you know, be a part of learning from you as well. So we can use this platform to do so. With that, I appreciate your time spending watching the video. If you have any comments, let me know. And don't forget to hit the subscribe button. Thanks.